My name is Dominique, and I'm a clinical nutritionist, and I make videos about lymphedema and health in general. Thank you for joining us today. It's a pleasure and an honor to welcome Dr. Chen, our speaker, who is a pioneer in the treatment of lymphedema using supermicrosurgery. He's also professor of plastic surgery and reconstructive surgery and co-director of the Center for Lymphedema Research and Construction at the Cleveland Clinic. Dr. Chen, welcome, and thank you so much for joining us today.
Thank you.
Well, great to be here, and I completely agree with what Dominic has said about lack of information, and that's why I'm here, just for you to ask questions and for me to provide information. And I think many of you may have been searching for information and may have been frustrated or feeling concerned or fearful because you are perceiving that people cannot help you. Your doctors don't understand lymphedema. And I can assure you that many of those are not true. And the main message today, I mean, we will discuss whatever questions you would like to discuss, but the main message that I want to bring you today is that lymphedema is treatable. No need to be fearful. You do want to seek accurate, timely diagnosis, and you need to be properly treated. And I think none of us, no matter how much experience we have, can claim that we know it all. And that applies to all branches of medicine. I don't think in any branch of medicine, whether it's cardiology, endocrinology, the internal medicine, general surgery, plastic surgery, whatever, I don't think we have all the answers. But we don't need to wait until we have all the answers before we start to help you. Patients cannot wait. Your conditions will not wait. So rest assured that I think it's fair to say that as of today, we know enough to provide meaningful treatment. And also, before we get into your questions, I need to explain that since I haven't properly evaluated any of you in person, it would be inappropriate for me to diagnose, and it would be inappropriate for me to provide treatment recommendation, individualized treatment recommendation. However, I can still help you by providing factual information, knowledge-based information. And so that's the first thing. That's a limitation of this webinar. Number two, also, please do recognize the fact that the field of lymphology is an advanced field of medicine, and it is cutting edge. Whenever you are looking at a field that is advanced, novel, and cutting edge, you're bound to find a lot of different opinions. And that goes for all branches of medicine. It's really not unique to the field of lymphology or lymphatic reconstruction surgery. So what I will be providing you represents my opinion. There are different opinions. There are opinions that are different from mine. There are even opinions that are sometimes opposite to my opinion. So please do keep that in mind. And it is a field that is rapidly advancing, and it is a field with a lot of different opinions. Okay, with that, yeah, let's get started.
Hi, Dr. Chen. My name's Martha. I live in Maine, and I've had lymphedema since 2001. I had malignant melanoma with 2 recurrences in the inguinal and then the deep iliac, radiation, 25 treatments of radiation. That was in 2000. So 2001, I presented. 2001, I had the radiation that presented lymphedema. I've been managing very well. I've had all the workup, MRIs, Lymphoscintigraphy, ICG at Beth Israel, and was a candidate for surgery. And I decided to wrap my leg for a year. I called it It's a Wrap 365. Wrapped my leg for a year, and I reduced my limb from 17% down to 4.8% and removed all hypertrophic fat. So now I am interested in this webinar because I'd like to learn more about your NLVA.
Okay, well, yeah, thanks for the question. So I think as I said, I can't directly recommend what you should be doing.
Correct.
With your scenario, it raises certainly several discussion points that I think will be helpful to everybody. First of all, understand that no one needs surgery. So surgery is a treatment option. And here is where my opinion is a little bit different from many of the other surgeons in the field. Many surgeons consider surgery second-line treatment, and that a patient would need to fail lymphedema therapy in order to consider the patient for surgery. So in a patient describing that he or she has been tremendously successful with lymphedema therapy, with non-surgical treatment, with compression, then many surgeons would say, then that patient is not a candidate for surgery. That's not how I perceive it. The way I look at lymphedema surgery is that it is a treatment option. So surgery or non-surgical treatment, both should be considered equally. Both have different pros and cons, advantages and disadvantages and limitations. So I think patients should be informed. When the patient is initially diagnosed with lymphedema or is put at risk for developing lymphedema, the patient should be informed about these two treatment approaches, since each treatment involves a lot more different treatment modalities. So we should be calling them treatment approaches, surgery or non-surgical treatment. And once the patient is informed, then the patient can decide which direction that he or she would like to move forward with. So there's some generalization that can be made about surgery versus non-surgical treatment. In general, surgery is, of course, invasive. Surgery is, of course, higher risk compared to non-surgical treatment. However, surgery usually can more fundamentally intervene and bring about more fundamental improvement. So if you observe many conditions that we manage in modern medicine, whether it's high cholesterol, high blood pressure, heart disease, diabetes, we're not providing fundamental treatment. We are providing effective management. We manage these conditions. So I have high blood pressure. I take blood pressure medication to keep my blood pressure in a decent range. That's considered a treatment success. So if that is something a patient, lymphedema patient, is looking for, just effective management, not necessarily a drastic fundamental improvement, then non-surgical treatment is just fine. There are, however, scenarios where non-surgical treatment has a low likelihood of success, and there are scenarios like that. For example, someone with already significant amount of fibrotic lipodystrophy deposits, who is already so lymphatic function is so compromised that the patient is considered regionally immunocompromised. The patient is developing nearly continuous infection and require continuous antibiotic. So in general, those patients frequently are very difficult to manage without surgery. And usually, despite best effort, best compliance from the patient, best effort from the therapist, those patients in general So anyway, those are some of the exceptions that patient clearly in those patients, surgery is that one treatment approach may be recommended over the other. You mentioned about the scenario of someone who is well managed. So I think it's important to understand the clinical stability, the stability of what we can observe. So an arm and a leg that is well managed, patient is super compliant with doing everything right. That's incredible. And that's excellent. That's what we want, and that's what patients should aim to achieve. At the same time, that is what we call clinical stability. The patient is well managed clinically. What about the underlying lymphatic system? We know that the lymphatic system usually changes that happen to the lymphatic system precedes clinical observation, precedes patient symptoms, which means that the lymphatic system can improve or deteriorate before the patients feel anything. So for all lymphedema patients, now this is where there's some different opinions, but in my opinion, all lymphedema patients deserve to be periodically monitored with imaging studies, what they look like initially, and what their lymphatic systems look like over time. So you mentioned various imaging studies. As of today, many of the imaging studies are not performed in standardized fashion, which means that, say, ICG lymphography performed in one institution, in terms of tracking purposes, if they're done differently, then the studies cannot be used for tracking purposes. Obviously, if you want to do comparison, the studies need to be done with all the parameters being the same. So that is something to be considered. Even lymphoscintigraphy, so frequently they're done differently from institution to institution with different delay time, different tracers being used. So as of now, many of these studies, if they're not done from the same provider, the same institution, they're not helpful for tracking purposes. They are, however, still helpful for diagnostic purposes, providing a qualitative answer, yes or no, whether the patient has or doesn't have lymphedema. All right, still another issue that your scenario has brought up is, well, you mentioned about the LNVA, lymph node to vein anastomosis. So frequently, well, because I understand that we have some reputation related to lymphatic supermicrosurgery. I have many patients coming to me requesting lymphatic supermicrosurgery. Sometimes they would come in and tell me, Dr. Chen, I know you are really good with this procedure. I want this procedure, even if I'm not a good candidate for it. So I want to let everybody know that there isn't a best procedure. There isn't one procedure that is better than every other procedures, all other procedures. However, there is a best procedure for a given patient scenario. So it's really not that, so LVA and LNVA or supermicrosurgery, they sound really cool, so they're better than liposuction. It doesn't work that way. A surgery is only a good surgery when performed with appropriate indication. So in terms of deciding which procedure to go with, it's a fairly involved process that takes into consideration of many factors. So I won't get into that for now. But it's more important for patient to know that there isn't one best procedure, and LVA or LNVA, which is our newest procedure, isn't better than any of the other procedure. And since you asked about LNVA, LNVA is connecting lymph node to vein. It's a procedure that connecting lymph node to vein. So it's conceptually very similar to LVA. And both LVA and LNVA connect lymphatic system to venous system. And the concept is based upon the fact that in lymphedema patient, the lymphatic system is not working very well. So we bypass to the venous system, which hopefully is working better than the lymphatic system. And therefore, the lymph now bypasses this ineffective lymphatic system and drains into the venous system, allowing venous system to take over the work. So both LVA and LNVA require functioning, or not require, I should say, how well the procedures work depend on the quality of the lymphatic tissues used. So in LVA, the better the quality of the lymph channels, the better the procedure would work. Same thing with LNVA, the better the quality of the lymph node, the better the procedure would work. Both procedures are considered physiologic drainage procedure, which means that it's not going to affect fibrotic lipodystrophy. And it will improve the patient's lymphatic drainage when successful, but it's not going to affect actual solid tissue deposits.
Mhm.
All right, I will leave it at that. I hope that's satisfactory. Oh, actually, a little bit more about the LMDA. So LMDA, actually, it's what's nice about it is that it's technically less demanding on the surgeon relative to LVA because the structures are larger. So for any surgeon who is experienced in LVA, I think adopting LMDA is relatively straightforward. And LNVA actually is not a brand new procedure. The procedure was originally developed by a Polish surgeon back in, I want to say, the 60s. And it was proposed as a promising procedure. However, the technique back then was a little bit, by today's standard, a little bit too destructive. It probably created too much of an injury to the lymph node and resulting in the procedure not working consistently. And the procedure has since then been modified and revised, and the credit goes to Professor J.P. Hong out of Korea, Asan Medical Center. And it's a procedure that we've been investigating and scrutinizing for several years until last year we felt that it was ready for clinical practice. It's been peer reviewed and the technique has been published and discussed at many major meetings. So we started offering that procedure last year. And yeah, so that's basically, I think, what would be helpful for patients to understand about LNVA. So now it's another procedure in our armamentarium against lymphedema.
So what is the process for diagnosing a patient if they are a candidate for the LNVA?
So I think it's important to understand the clinical stability, the stability of what we can observe. So an arm and a leg that is well managed, patient is super compliant with doing everything right. That's incredible. And that's excellent. That's what we want. And that's what patients should aim to achieve. At the same time, that is what we call clinical stability. The patient is well managed clinically. What about the underlying lymphatic system? We know that the lymphatic system usually changes that happen to the lymphatic system precedes clinical observation, precedes patient symptoms, which means that the lymphatic system can improve or deteriorate before the patients feel anything. So for all lymphedema patients, now this is where there's some different opinions, but in my opinion, all lymphedema patients deserve to be periodically monitored with imaging studies, what they look like initially, and what their lymphatic systems look like over time. So you mentioned various imaging studies. As of today, many of the imaging studies are not performed in standardized fashion, which means that, say, ICG lymphography performed in one institution, in terms of tracking purposes, if they're done differently, then the studies cannot be used for tracking purposes. Obviously, if you want to do comparison, the studies need to be done with all the parameters being the same. So that is something to be considered. Even lymphoscintigraphy, so frequently they're done differently from institution to institution with different delay time, different tracers being used. So as of now, many of these studies, if they're not done from the same provider, the same institution, they're not helpful for tracking purposes. They are, however, still helpful for diagnostic purposes, providing a qualitative answer, yes or no, whether the patient has or doesn't have lymphedema. All right, still another issue that your scenario has brought up is, well, you mentioned about the LNVA, lymph node to vein anastomosis. So frequently, well, because I understand that we have some reputation related to lymphatic supermicrosurgery. I have many patients coming to me requesting lymphatic supermicrosurgery. Sometimes they would come in and tell me, Dr. Chen, I know you are really good with this procedure. I want this procedure, even if I'm not a good candidate for it. So I want to let everybody know that there isn't a best procedure. There isn't one procedure that is better than every other procedures, all other procedures. However, there is a best procedure for a given patient scenario. So it's really not that, so LVA and LNVA or supermicrosurgery, they sound really cool, so they're better than liposuction. It doesn't work that way. A surgery is only a good surgery when performed with appropriate indication. So in terms of deciding which procedure to go with, it's a fairly involved process that takes into consideration of many factors. So I won't get into that for now. But it's more important for patient to know that there isn't one best procedure, and LVA or LNVA, which is our newest procedure, isn't better than any of the other procedure. And since you asked about LNVA, LNVA is connecting lymph node to vein. It's a procedure that connecting lymph node to vein. So it's conceptually very similar to LVA. And both LVA and LNVA connect lymphatic system to venous system. And the concept is based upon the fact that in lymphedema patient, the lymphatic system is not working very well. So we bypass to the venous system, which hopefully is working better than the lymphatic system, and therefore the lymph now bypasses this ineffective lymphatic system and drains into the venous system, allowing venous system to take over the work. So both LVA and LNVA require functioning, or not require, I should say, how well the procedures work depend on the quality of the lymphatic tissues used. So in LVA, the better the quality of the lymph channels, the better the procedure would work. Same thing with LNVA, the better the quality of the lymph node, the better the procedure will work. Both procedures are considered physiologic drainage procedure, which means that it's not going to affect fibrotic lipodystrophy. And it will improve the patient's lymphatic drainage when successful, but it's not going to affect actual solid tissue deposits. All right, I will leave it at that. I hope that's satisfactory. Oh, actually, a little bit more about the LMVA. So LMVA, actually, it's what's nice about it is that it's technically less demanding on the surgeon relative to LVA because the structures are larger. So for any surgeon who is experienced in LVA, I think adopting LMVA is relatively straightforward. And LNVA actually is not a brand new procedure. The procedure was originally developed by a Polish surgeon back in, I want to say, the 60s. And it was proposed as a promising procedure. However, the technique back then was a little bit, by today's standard, a little bit too destructive. It probably created too much of an injury to the lymph node and resulting in the procedure not working consistently. And the procedure has since then been modified and revised. And the credit goes to Professor J.P. Hong out of Korea, Asan Medical Center. And it's a procedure that we've been investigating and scrutinizing for several years until last year we felt that it was ready for clinical practice. It's been peer reviewed and the technique has been published and discussed at many major meetings. So we started offering that procedure last year. And yeah, so that's basically, I think, what would be helpful for patients to understand about LNVA. So now it's another procedure in our armamentarium against lymphedema.
Thank you.
Anyone else has a question?
So what is the process for diagnosing a patient if they are a candidate for the LNVA?
So I think in general, when it comes to treatment, we initially need to discuss with the patient, making sure that the patient has sufficient understanding about surgical versus non-surgical treatment. Once the patient has decided that he or she wants to move forward with surgical intervention, we, again, I'm saying we because I can only speak for ourselves. We inform the patient that there are different opinions in the field. So the procedures that they will receive is likely to vary from institution and surgeon to surgeon. Mm-hmm. Even given the same procedure, let's say LVA. Well, as of today, I'm not aware of other American lymphedema surgeons performing LMVA, but I think it's only a matter of time. I think soon American surgeons will adopt this technique. But even, let's say, LVA or lymph node transfer, depending on the surgeon you go to, you're likely to receive a different procedure. So patients should understand that, and we do encourage that patient research on the surgeon, research on their treatment philosophies, treatment approaches, and then decide on who they will go to. And if the patient decided to pursue treatment with us, then we go in further about how we decide which procedure, the rationale for selection of the procedure. But in general, patient with significant amount of solid disease would benefit from debulking liposuction. And the debulking liposuction, so contrary to popular belief, debulking liposuction, at least with the way we perform it, does not harm lymphatic drainage. So IC talks about lymph-sparing liposuction. At least the way we perform debulking liposuction, it's unnecessary. Not only that it doesn't harm lymph drainage, it actually improves lymph drainage. The mechanism is we're still investigating what the mechanism is, but consistently we observed with ICG lymphographic evidence improved lymph drainage following lymphatic debulking liposuction. So, which means that debulking liposuction isn't just debulking, it's also improving lymph drainage.
Okay.
And for many patients, especially upper extremity lymphedema patient, following debulking liposuction, they already are doing incredibly well, and many of the patients would choose to not undergo any further surgery. For lower extremity, I think it's more likely that further procedure would be still beneficial. So whether further surgery is still indicated is partially medical and partially individual decision. And if the patient is still interested in further lymphatic reconstruction, going way back, for me, by the way, this is called a hybrid reconstruction, debulking first, reconstruction later. Going way back early in my practice, I would do lymph node transfer. Later on, it became lymph vessel transfer. And still later on, it became LVA. And currently, it's LVA and or LNVA. So we would do debulking first, and then LVA and or LNVA. The choice between LMVA and LVA comes down to the understanding that both procedure exerts a catchment regional effect and a systemic effect. It means that the catchment effect means that if the patient has leg swelling below the knee, a bypass procedure in the leg will likely exert more benefit compared to, say, a bypass in the groin. Versus a patient with abdominal and genitalia swelling, a groin LNVA bypass is likely to work better than an LVA in the leg, even though an LVA in the leg would still help with swelling in the genitalia, in the lower abdomen, even in the other leg. Although when you consider the regional catchment effect, if you place a bypass right there where the patient is symptomatic, it's likely to work better. So that's how we approach our LVA versus LMVA, and how we approach the decision overall of which procedure to go with.
I currently, Dr. Chen, I see a lot of patients who have the disease and they are unaware of it. Because I have been around you and I have been around people who have this disease, I can now recognize the signs. Where can I send them to get a proper diagnosis?
Okay. All right. I will actually, instead of telling you, we will get to where to send them. But I think before that, it's important for patient to recognize, first of all, recognize that they may be at risk, and also recognize some of the early sign. The first thing to recognize is that swelling is not an early sign. Swelling is a late sign. Before a patient swell, the first day that the patient swell, that person's lymphatic system have been desperately compensating for a long time already. And actually, it's not so accurate to say for a long time. It depends on the severity of the initial injury. If the initial injury was severe enough, there's a compensatory process that the body is trying to heal itself. The body is trying to compensate. If the initial injury was too severe, then that patient is likely to have a relatively short compensatory process, and fairly quickly the body gave up and the patient became symptomatic. Versus someone with a milder injury, then it could be a prolonged compensatory process. For example, a patient with breast cancer, after having breast cancer treatment, the patient may develop arm swelling far out from the actual treatment. It could be 6 years down the road, it could be even 10 years down the road, And at that time, the oncologists have already stopped following the patient. So the oncologists weren't even aware that these patients developed lymphedema later on. And we know because these patients came to us. So now that brings us to the lymphatic injury. We know that there are certain things that cause a lot of lymphatic injury, and there are things that don't really matter. So first of all, don't worry a whole lot about that you sprain ankle or you have torn a muscle from rigorous activities, or you had a shot, or you had a blood draw, you had a blood pressure cuff, you got stung by a bee, you got stung by a cactus, you were slapped by your spouse. These were all reports of causes of lymphedema that we have heard, that we reassure the patient these things don't cause lymphedema. Your lymphatic system isn't that fragile. It's actually quite robust. What constitutes significant lymphatic injury? A complete lymph node dissection, a full lymph node dissection. So a full axillary lymph node dissection, a full pelvic lymph node dissection, a full inguinal lymph node dissection. Now, these constitute severe lymphatic injury, but frequently not the sentinel lymph node dissection. If they take out 1 or 2 lymph nodes, that usually constitutes insignificant injury that your body can still compensate. With that said, we've also seen patient having had sentinel lymph node dissection in which the surgeon removed 8 or 9 lymph nodes, and they're still called them sentinel lymph nodes. So, of course, the more lymph nodes removed, the more injury that was inflicted. But in general, surgical trauma, if we have to put them on a scale, which one is worse, radiation or surgical trauma? I would say radiation is worse. In animal model, that's probably the most reliable way to produce lymphedema, because surgical trauma body, especially in animals, they can usually heal from surgical trauma. But radiation can really fry their ability to regenerate, to repair themselves. So with that, you can speculate that most likely in someone who had both, you have lymph node dissection and radiation, are high risk. So I think all patients with that history, they are advised to be proactive and seek out lymphatic imaging to find out where they stand. And frequently, for a patient who had lymph node dissection and radiation, even if they're asymptomatic, we can already see clearly defined lymphatic injury, and based on the severity of the lymphatic injury, we can make a prediction and whether we should be proactive or we can still sit tight and treat the patient expectantly with observation. As far as where should the patient seek out these lymphatic imaging, I think now the availability of lymphatic imaging is much more widespread than it used to be. And many of you probably know already that indocyanine green lymphography is the new gold standard. And lymphoscintigraphy is also helpful. Lymphoscintigraphy is more widely available than ICG lymphography, but whenever ICG lymphography is available, that would be, in my opinion, the superior studies, and there are evidence available that show ICG lymphography being more sensitive, especially if you're trying to detect really early disease. We see time and time again in our practice that patients who have previously had negative lymphoscintigraphy would come in, receive our ICG lymphography, and then had detectable disease. Now, with that said, currently ICG lymphographies are almost exclusively offered by lymphedema surgeons. And by the way, as far as I know, all lymphedema surgeons are plastic surgeons, including myself. I'm a plastic surgeon. specializing in lymphatic supermicrosurgery. And as you know, surgeons are not radiologists, so surgeons may or may not be invested to get all the relevant equipment and equip themselves with all the relevant experience and knowledge about imaging studies. So that's where we see some variability in terms of the ICG lymphography. But assuming both studies and their optimal results, conducted in optimal fashion, ICG lymphography is, in my opinion, the superior study. Patients are certainly encouraged to reach out to their local major medical systems. I think most of the major medical systems do possess these technologies. And I think patients can be openly inquire about their experience. How experienced are they? How frequently do they perform ICG lymphography to diagnose lymphedema?
Okay.
How many cases do they do, say, in a month, in a year? So all these are objective numbers that I think yeah, it can be a little bit awkward to ask. But I think as providers, we should all understand that this is a novel field. So I think it is a legitimate question. And thank you for bringing up this very important subject. And I think so again, we want to initially approach this question from a high level. When we undergo surgery, the first requirement is safety. We want surgery to be safe. And once we have ensured safety, number two is we want the surgery to be effective. So safety is number one, and then number two is efficacy. So now with those two requirements in mind, let's look at this issue of being heavy. So we have, there are evidence and published studies demonstrating that being heavy by itself can cause lymphatic injury and resulting in lymphedema. That is well demonstrated. And it's also well demonstrated that as we gain weight, precisely at what level it starts, it's a bit uncertain, but we know that as we gain weight, we are starting to stress out our lymphatic system. The lymphatic drainage become progressively more inefficient. Lymphatic stasis increase. And this is especially true for lower extremity lymphedema. This is especially true for lymphedema in the more dependent body parts. So there are patients who are so heavy that surgery, any form of surgery, is completely contraindicated. If we operate on the patient, we're likely to harm the patient. The patient is likely to experience a bad complication. So I think as a surgeon, regardless of what kind of surgeon we are, rule number one, do no harms. We need to ensure our patient's safety. That's what I just said. It is not the patient's job to know that surgery is bad for them. It is our job to safeguard our patients. So we need to, for those patients, we need to let them know surgery is clearly not in your best interest. Now, so that's one group of patients. And those patients usually have extreme BMI, and I think those patients are, that's fairly black and white. Now, the second consideration, as I've just said, we want the surgery to be effective. So if you think about lymphedema, what is lymphedema? Most frequently, we don't discuss about lymphedema of the superficial lymphatic system and lymphedema affecting the deep lymphatic system. So in a lymphedema patient, the patient may simply have superficial lymphedema, or the patient may have lymphedema affecting both of their deep and superficial systems. I'll give you an example. A breast cancer treatment-induced lymphedema, arm lymphedema, affects both the superficial system, which drains the subcutaneous fatty space, and the deep system that drains the muscular space. Okay, so that's a breast because their lymph nodes in the armpit were removed. And that's where the superficial and deep system converge. Whereas, say, a melanoma patient who had inguinal lymph nodes removed, and that patient sustained injury to only superficial system. The deep system drains directly to the pelvic lymph nodes, remain preserved. So that patient will still have a functioning deep system. But for the most part, when people talk about swelling, they're really talking about what they observe, swelling of the superficial system or swelling of the fatty space. So we'll exclude for the discussion, for the ease of discussion, we'll exclude the deep system issue for now, the muscle swelling for now. Usually when people talk about swelling, they're not going to see muscle swelling. So what they see is swelling in the fatty space. So what does that mean? That means the more fat that we have, the worse our swelling is going to be, because we're providing lymphedema a bigger tank. So lymphedema has a bigger tank to fill it with fluid. So the opposite is also true. If you have less fat, you're going to have less swelling, and your swelling would be easier to manage. You won't need as strong a compression garment. You will be more responsive to compression. So when it comes to treating lymphedema patient, going back to what we were discussing, deciding surgical versus non-surgical treatment, both can be highly effective. And for a different patient, the treatment needs to be tailored to individual patient. So let's say a patient with BMI of 38, what would be the best for that patient right now, in addition to working with the therapist, wearing effective compression garment, using pneumatic pump, elevation, lifestyle modification, proper diet, exercise, and all that? Is surgery the best time? Is that the best time to operate on that patient? No. That patient, comparing to weight loss for a patient with BMI of 38, let's say weight loss to a BMI of 30 compared to surgical treatment on that patient, which one would I say would be more effective? I would say weight loss would be more of an effective treatment for that patient, because not to mention it's safer, and also not to mention surgery is not going to work as well when the BMI is at 38. So to put it simply, in my opinion, the best treatment, the most effective treatment for that patient, lymphedema patient with BMI of 38, in addition to receiving all of the standard non-surgical treatment, would be weight loss. And possibly some of you have personal experience that when you have lost weight, your lymphedema seem to be more well-behaved. But I think the situation with BMI, with patient being heavy, is partially due to the reluctance of all of us from not willing or feeling uncomfortable talking about weight. I think the situation is further exacerbated by the fact that all of us are being Google reviewed. So many providers are concerned about their review ratings. Are they getting 5 stars on Google reviewed? And I can tell you the easiest way to get a 1 star or no star is to talk to the patient about weight loss. And but I think whenever we are faced with a difficult situation, we should ask ourselves, what is the right thing to do. And I think as a physician, patient came to us, yes, they want to feel better, but they also need to know what they need to do to start to get better, to really get better, not just psychologically, emotionally feeling better. So I think patient needs to be told what they need to know in order to start to get better. So instead of thinking that my providers are just telling me that I'm overweight, I need to lose weight, so the provider doesn't know anything, think of it as there aren't too many things. There are things that are outside of our control, outside of a patient's control. The weight is one of the few things that a patient can do that will very powerfully, very effectively improve their lymphedema. So why wouldn't they do it? I can tell you 100% of the time, my patient get better when they lost weight. Of course, it's not a cure. Weight loss by itself is not going to cure lymphedema, but it's certainly highly therapeutic. And for someone who is significantly overweight, weight loss is a priority. Weight loss is therapeutic. And the efficacy of weight loss cannot be understated. It's so powerful, so effective. And provided that the patient is willing to hear us out. So, yeah, so that's really the consideration related to weight.
When I met with you last September for our first consultation, and you told me to concentrate on fat loss and not weight loss. I said to my husband later, I said, I really didn't think that I was fat. I considered myself within, a normal weight range, but I took your orders and I worked hard and lost 15 pounds or so before the surgery and got into good shape. And I attribute that to the way I'm feeling today. I feel like I'm doing quite well in my recovery.
No, thank you for sharing that. So to be more accurate and precise, it's not really the BMI. As I said, the enemy is really fatty tissue. So even for people who have a healthy BMI, which is less than 25, we see what we call a fat, skinny person. So this is a person who has appropriate weight, but due to various factors, lifestyle factors, has a very high body fat percentage. For patients like that, we also recommend working on losing their fat, trying to decrease their fat percentage, trying to shrink the tank, the lymphedema tank, if you will. That will very directly improve their swelling and improve their symptoms. Yes, that's another great question about primary lymphedema. So primary lymphedema, in our experience, by the way, we see many in my patient population. We see more primary lymphedema than secondary lymphedema, probably because some providers don't treat primary lymphedema, and I think the reason is primary lymphedema in general is a more challenging entity compared to acquired lymphedema. Like lymphedema is also more challenging compared to ARM. So a primary like lymphedema is, relatively speaking, the most challenging entity. So when it comes to primary lymphedema, it's important for patients to recognize that it's, in our experience, it's not a regional condition. So even if you only have swelling in, let's say, left leg, primary lymphedema is actually a condition that affects your lymphatic system systemically, which means that if we perform diagnostic study, imaging study in your arm, we're likely to find lymphatic insufficiency in the arms as well. In the other leg, we're likely to find insufficiency in the trunk, face, we're likely to find insufficiency. And even though they are completely asymptomatic, but whether a body part would swell or not comes down to the balance of lymph drainage and production. As long as a patient is draining enough, has sufficient function, drainage capacity, you're not going to see swelling. So these are areas that are at risk, and therefore, that's the first consideration. Primary lymphedema is systemic from our experience. And actually, we're about to finally move forward with our study on this, and we have fairly convincing evidence of this. Previously, when I was in Iowa for 9 years, we also had fairly extensive evidence on this, although since I had relocated, those data are no longer retrievable. So this is something that we have consistently observed, that primary lymphedema affects our body globally. And the second factor to consider is this age-related loss of lymphatic function. And this should come as no surprise. As we know, with aging, we start to get weaker, we start to become more deconditioned. We lose muscle mass, we lose bone mass. All of our bodily functions start to decline, and so does our lymphatic function. This is happening to all of us, whether people with or without lymphedema. We all lose lymphatic function with age, and this was shown by a Japanese study. And this age-related loss of lymphatic function occurs faster in female. Kind of analogous to how female lose bone density faster than male. And this may partially explain why we tend to see more female lymphedema patients than male. But it's happening in all of us. So as you can imagine, given the two things I've just said about primary lymphedema, a patient with primary lymphedema may have no issues throughout most of his or her life, and then became symptomatic in his or her 30s or 40s or 50s. The oldest primary lymphedema patient I have seen develop swelling in her 70s. And of course, it wasn't attributed to primary lymphedema. It was attributed to, I can't remember what, it was attributed to one of the minor event, such as spraining ankle or had knee replacement surgery. None of these are really sufficiently damaging to the lymphatics. But what that patient truly had was primary lymphatic insufficiency and being triggered by age-related loss of lymphatic function. Now, with what I've just said, you already know that in these patients, it's best that we avoid any of the transfer procedure, and that would include lymph node and lymph vessel transfer, because any of the transfer procedure, whether we transfer from the neck, transfer from the side of the chest, from the groin, from inside the abdomen, omentum, jejunal mesentery, we're always borrowing from Peter to pay Paul. We're always weakening another part of the body. We're always damaging another part of the body's lymphatic system. So, by the way, leave it to the patient herself or himself. Very frequently, we see primary lymphedema patient initially developing symptom in a part of the body. And I can tell you, because we have just completed our retrospective review, 70% of the primary lymphedema patient initially develop swelling in their left leg. And many of these patients over time develop swelling in the other leg. And then subsequently, another part of the body. It could be hand, arm, it could be face, could be chest, could be abdomen, could be buttock. But most frequently, patients develop symptoms in one leg. So even without additional injury, artificially created loss of lymphatic function, such as performing a lymph node transfer, harvest, or lymphatic tissue transfer, these patients are already at risk. So I think a general guideline for patient with primary lymphedema is we need to work on preserving all of your lymphatic function. We shouldn't cause any injury. So this is where some surgeons have different opinions. Some surgeons don't really make that distinction of primary versus secondary lymphedema. They have been getting great results with lymph node transfer. They would treat everybody with lymph node transfer. I think there are less and less surgeons who think like that. Where I think the trend is moving towards more tailoring the treatment to individual patient, but there are certainly still surgeons who fully embrace one procedure. At the same time, there are surgeons who fully embrace liposuction or LVA, that they would treat everybody with the hammer and nail approach. I think patients should be aware of that. And at this point, since there's ongoing controversy, we're not in a position to say who's right or who's wrong. It's simply that there's a lack of consensus.
I have one thing that I would like to answer for us about the primary lymphedema. So is this accurate to say that if someone has primary lymphedema, it's existent, but it has not manifested, if they keep normal body weight and a low fat content in their bodies, would that delay the manifestation of the disease?
I think that would be a hypothesis that would make sense given our current understanding of primary lymphedema. So I would agree. I think for someone with primary lymphedema, actually anyone with lymphedema, that applies to acquired lymphedema also, live a healthy lifestyle, maintain a lean body composition, and avoid being overweight. Diet, which we haven't gotten into for sure. I mean, you're a dietitian, Dominic. There's a lot that you can contribute to lymphedema care. Diet is under-investigated. There are already a lot of people talking about anti-inflammatory diet, intermittent fasting, but none with really, in my opinion, high-quality evidence. So far, these informations are all anecdotal. We need formal studies. We need proper investigations. And for sure, I mean, we know that we are what we eat. And I have no doubt that diet would would have profound effect on management of lymphedema. But as of today, it's underexplored, underinvestigated.
So, Dr. Chen, I think you're asking me to write my next book.
Yes, of course. But I think it's completely fine to start out with anecdotes. Modern medicine actually originated from anecdotes. 100 people reported that eating certain things, doing certain things help with lymphedema. But then we shouldn't stop there. That's not even level 5 evidence. An expert stating something without proper objective evidence, that's level 5 evidence, is simply what I'm telling you. But then we need to go a step further to properly investigate. So I think the proper attitude is that we need to keep an open mind. However, we need to question everything. So whenever you see a claim, now the medical literature isn't exclusive for medical professionals. You all have access to medical literature. So when you see a claim, for example, low-level laser, which has been shown to be promising in treating male pattern baldness. You probably have seen those cap that men can wear to promote hair growth. It has some evidence behind it. However, we have seen providers starting to promote using the same technology to create a mattress that people lay on it, claiming that it would mobilize fat and allowing them to lose fat. So things like that, you certainly can do your own research. Look into the medical literature, what has been said about it, and you can make your judgment. Is this anecdote? Is this fake? Or is this something that is being investigated? Or this is something that has been investigated and proven effective or proven ineffective. So that's what I think when it comes to lymphedema, there's certainly a lot that is already investigated that we already know. There are lots of things that we are investigating. For example, the lymphatics of the brain. That some of you might have heard my other talks that we've discovered. No, I shouldn't say that we discover. We are investigating the possibility of treating these brain disorders because now we know they are really lymphedema of the brain. So that is under investigation. We can't really make a conclusive claims yet, but it's certainly very exciting and very promising. So that's what we can say about it.
Kim has a question about, I think, the laser.
I had the Matisse surgery done in April with you, Dr. Chen, and you said 25 pounds of pressure in my calf when we did the surgery, but I never got to ask you because I haven't heard a lot of people talk about that. How do you keep that muscle pressure from rebuilding? Is that just something that happens that you can't change? I'm primary. I'm the one that we've done the ICG, and you didn't find anything in my other limbs, thank God.
What can you do to prevent recurrence? Am I correct? Is that's your question to prevent these abnormal tissues from building up again? Is that what your question is about?
Well, when we did the surgery, the whole thing about releasing the muscle pressure
Okay.
we didn't talk about that a lot, or I didn't recall it. So now that I think this muscle pressure got released, because you said it was very high, is there anything I can do to keep that from happening? Did I make that happen, or does that just happen with lymphedema and leukemia?
Okay. Yes, that's a great question. And so again, I'll need to preface this by saying this is in our experience. We have observed this phenomenon of lymphedema patient developing very thick and rigid encasing of their muscles. And essentially, the fibrotic process has involved not only their fatty tissues underneath the skin, but also the lining of their muscle. We call fascia. Muscles are covered and wrapped by fascia. Now, these fascias are not supposed to be dense and rigid like cement. They're supposed to be yielding. So when we exercise, when we exert ourselves, we have improved circulation to the muscles, so the muscles receive more blood supply. And that's the pump that we feel when we work out with weights. So that sensation of the pumpness, is the muscles expanding. And the muscle expanding against the fascia, that's that sensation. So in lymphedema patient, particularly in the leg usually can get worse than the arms because the leg is much more dependent than the arms. Patient with leg lymphedema can develop, due to chronic inflammation, this abnormally thickened muscle fascia, preventing the muscle from expanding. So the end result is some patient will report this cramping sensation in their leg when they exert, or sometimes pain, and the pain could go from a dull pain to excruciating stabbing pain, or numbness in the muscle. or simply exercise intolerance. And that's due to the development of this rigid encasing muscle fascia. So the best way to prevent that from happening is proper management of lymphedema. So all patients who got to the point of needing Matisse procedure have developed significant amount of lymphedema fat deposit, and all the patient developing significant amount of fibrotic tissues are said to have, well, let's use a staging system. Let's say Campisi staging, that would be a stage 4 disease. Following a thorough removal of these abnormal tissues, assuming, now for the ease of discussion, complete removal, normalizing removal of abnormal tissues, these patients are said to be normalized to or downstaged to stage 1B on Campisi staging. So this is a time when patient experience reversible swelling, normalizing in the morning and worsening in the late day from swelling. So the best thing to prevent recurrence would be proper adherence and proper management, proper use of compression garment, changing out, making sure that their compression garment is achieving optimal containment, which means that when they wear their garment, they have no swelling. And wearing their compression garment for sufficient amount of time and changing out their garment whenever the garment becomes ineffective. That means at least every 6 months. And that means whenever their shape changes. And yeah. So essentially, answer to your question, to prevent recurrence, proper, effective, ongoing management.
Dr. Chen, can you say tell us what the acronym stands for in MTSE, that procedure?
Okay. Matisse is yeah, I think patient might get confused by the name Matisse and Sapple and whatever else you want to call. So these are essentially removal of lymphedema tissue using liposuction. And why do people call it? Well, Sapple is really coined by Dr. Granzow, and many people do call it Sapple. We call it Matisse, and that's just our terminology. But whether it's Sapple or Matisse, it both started. Well, I can certainly tell you how it got started with us. It was because the moment you use the term liposuction in our document, that's the moment when insurance will not cover that patient. Insurance, in the eyes of insurance reviewers, liposuction is a bad word. So, so these terms were really coined for that purpose. It's not, yeah, essentially it's removal of lymphedema tissues using liposuction. Liposuction is simply a technique that is used to remove these abnormal tissues.
Margaret has a question. She raised her hand. Go ahead, Margaret.
Wouldn't you want to get the surgery earlier before the later stages?
Yeah, I'm glad you brought this up. This is a very important question. But essentially you're asking about timing of surgery. When should you consider surgery? My recommendation is to start out understanding your treatment options, both surgery and non-surgical treatment. They have their pros and cons, and just that discussion alone is extensive. And once you have decided, assuming that surgery appeals to you, and there's a lot of factors to consider, but let's say you decided that you want to be surgically treated. Once that decision is made, then you ask, when is the best time for surgery? Well, short of, there are exceptions, and we discussed about weight loss and all that. Assuming none of those, then the earlier the better. So let me just repeat that again. Initially deciding surgery or non-surgical treatment. And I think both are equally worthy, and both, that's extensive consideration and discussion about which one a given patient should go with. But if you do decide that you are interested in treating your condition with surgery, and in the absence of contraindications, the sooner the better. You probably have heard of, you may or may not have heard of surgeons offering preventive surgery, which means that surgery is done on patients who are put at risk of developing lymphedema, but they haven't developed symptomatic lymphedema yet. We would offer surgery to those patients. So there's, given that, there's absolutely no reason to wait until the patient to get worse, and now we are treating them with surgery. Essentially, the earlier the patient undergoes surgery, now this would be a generalization, and it's true most of the time, not 100% of the time, but most of the time, the sooner and the earlier the patient undergoes surgery, the less technically challenging the surgery will be. And usually we can offer the less invasive surgery. And in general, the better the surgical outcomes. The best possible outcome, of course, would be when we nip lymphedema in its bud. That lymphedema doesn't even develop. And that's when we offer surgery proactively to patients who are at risk of developing symptomatic disease. And as we have just discussed, those who had lymph node dissection and radiation.
Thank you, Dr. Chen. I have one last question, and then we'll wrap the meeting. So here's a hypothetical patient. Someone comes to see you who has it in the leg, and you do the Matisse procedure. The person is doing very well, very healthy, takes no medication, great shape, low body fat, and now you're going to perform the LVA on this patient. Does that patient have a chance of, we're going to call it 90% cure?
Because the topic of cure. All right. So, by the way, this really should be a lecture, but I will try to do justice with just a few sentences. And I think it is meaningful for me to share this, because I know many of you suffered, at least partially, due to the lack of hope. And yes. So I'm happy to share with you that lymphedema is curable. And I know many surgeons disagree because they simply haven't observed this cure phenomenon. They haven't cured any patients. But I think all of us can only comment on our experience. Why other surgeons haven't cured, we don't know, but we certainly have. And by the way, we have our manuscript finally got accepted by a journal about this phenomenon of lymphedema cure. And I can tell you, I initially started submit this manuscript, I want to say 7-8 years ago.
Oh my goodness, it's slow.
And I couldn't get it accepted just because this is analogous to telling the scientific community that the Earth is round when everybody believed that the Earth is flat, or that we are not in the center of the universe when everybody else thinks that otherwise. So, but even for us, well, first of all, lymphedema in our experience is curable. However, despite our best effort and despite us standardizing our treatment, we are achieving that very uncommonly, and that's only observed in a small percentage of patients. But since we treat a lot of patients, so we do see it consistently every year. A small percentage of our patients achieve the status of cure. So what does that mean, cure? Cure means the patients are no longer symptomatic, they no longer swell, and they no longer require any further treatment. So a lot of providers, physicians don't like the term cure. They feel that it's a little bit too strong and it promises a little bit too much. So we certainly are open to calling it whatever people feel more comfortable with. But that is the state that our patients have achieved, a full reversal of disease, no longer symptomatic, and no longer requiring any further treatments. And the thing is, usually when these patients achieve that state, they don't come back anymore. So our follow-up becomes incomplete. And so that is what we have achieved. So lymphedema is curable, and right now only few surgeons around the world agree with me. Most of the American surgeons would disagree with what I have just said. And then, as I have said, that arm lymphedema is less challenging to treat than leg. Acquired lymphedema is less challenging to treat than primary. And adult lymphedema in general less challenging to treat than pediatric. So with all that, you know that the best combination, and also that is what we see, the population with the highest cure rate, or most likely to observe this cure phenomenon, would be in those with post-mastectomy breast cancer related arm lymphedema. These are adult acquired upper extremity lymphedema. On the other hand, the pediatric lower extremity primary lymphedema is the other extreme. But if that happens to be what you have, don't worry. We still have effective treatments that yield satisfactory results for this patient population. But relatively speaking, that certainly is the most challenging entity.
Okay, this has been really an eye-opener, lots of information. I'm glad we recorded it because many of us will go and listen to it again. But I have to say there are lots of course, good surgeons out there. What impressed me about Dr. Chen when I saw his papers and his videos years ago, he's the only one who gives us hope. He's the only one who says a cure is possible. And I'm here to tell you, I have seen lots of people actually who have been cured. It is possible. So it can happen to you. The important thing is to seek treatment, to weigh all your options, to do all the digging you can dig on the internet, find out who is the best person to treat you. But most importantly, don't give up and don't believe it's impossible. There is no such a thing. I do have a couple of announcements. We just created a new Facebook group. I would like for you to join. This group is going to be different than what you are used to because I'm creating a volunteer association to help people who are either diagnosed or suffering from it. And people who have undergone surgery. It is all free information. I have lots of tools. I have lots of resources to share. We are also going to start a support group where we're going to be meeting online monthly. So make sure you register. And for full disclosure, I would like to add that I am not affiliated with the Cleveland Clinic, and I'm not a physician, because lots of people have been asking me questions. Dr. Chen, thank you so much. It's been a pleasure and really an honor to have you talk to us today. And if you have any you want to reach Dr. Chen, let me know. I have the information. Thank you.
Yeah,
Thank you.
if I can say two things. So you probably have personally experienced how difficult it is for you to find lymphedema expertise. And it's like that for a reason. As of today, the practice environment is hostile towards lymphedema practitioners. Insurance coverage is difficult, and medical establishments usually are under reimbursed or frequently not paid for these services. And that is why it's so difficult for you to find lymphedema expertise. So I would encourage all of you to be vocal about this situation and to help each other. The insurance has the angle and are in a position to decline coverage exactly because lymphedema isn't talked about enough. And so I definitely encourage you to help each other to be vocal about this deficiency in our current medical community, and to help each other by letting others know that treatments, effective treatments, are available. But providers, we don't have enough providers because surgeons and physicians don't want to go into the field because it's so difficult. It's so well, not that the procedures are difficult. They're difficult, but they never stop any surgeons. What's difficult is the environment is so unfavorable, and that's why you're not getting the help you need. That's the first thing. And the second thing is um, now, because of our collective effort in the past decade, now we are having a lot more physicians. Now, many of these are young physicians who are passionate about helping you, helping lymphedema patients. They may not have decades of experience, but they want to help. And all of us, more senior physicians, experienced physician, we were once inexperienced. So if you work with your local physician, give them feedback. I'm sure. So we are also learning from all of you. As I said, if you're cured 3 years out, if you don't come back, we don't have that data. We didn't know that you're cured.
Yeah.
And if whoever you are working with, give them the feedback. And if you're cured, you're having a great outcome, you no longer need us, that's great. We're very happy for you. But do let us know, because your experience and what has happened to you will allow us to help others. What we are learning from you would allow us to help others. And definitely also let your local lymphedema doctors know, because they need to know. They don't need to know a lot about how to treat lymphedema, but they should know enough to recognize that this may be lymphedema, and they need to know enough to make appropriate referrals. So that's what I would ask of all of you. And yeah, let's help each other and help us help you.